Have people admitted. Okay, everyone. Well, this is pretty good. 5 minutes late. That's not too bad. We're moving along. We're within that 10-minute area that my college students used to say. That's right. Give us 10 minutes, and then we'll be late after that. Okay, are we ready to go? Okay, good morning, everyone. We had a little technical difficulty this morning, but I hope everything is working. If we have anyone who is having difficulty hearing or seeing us, would you please raise your hand or put it in the chat? Hearing none or seeing none, I am thinking we are okay to go ahead, and we will open the meeting for the Commission on Aging. Today's meeting is now in order. The first order of new business that we have would be election of officers, but first of all, we need to take roll and see who's here and see if we have a quorum. So let me go through roll call, and that's the first thing we will do. Margaret, are you on? Margaret Smith? On the phone or on virtually? Okay. Katie, are you on this morning? Katie Ellman?
Yes, good morning.
Good morning, Katie. James Goen. James, are you on this morning? Okay. Kelly Tungate. Kelly, are you on this morning? Okay. Kelly, are you muted? Hi, Kelly. We see you, but we can't hear you. Okay, maybe our IT people can take a look at that and see what's going on. Kelly, I'm going to count you as here. We can see you, but we can't hear you. Dan Mustard is present. Here. Bob Bischoff? No. Okay, I should do something with that. Okay, I am here. Judith Schoon. Okay, we must be having audio problems here in our, we can't hear you. Can you hear in different rooms? How do you hear us?
No, we can hear you loud and clear.
Okay, I'm counting Judith here. Jennifer Lance is here. Megan Springer. Megan, are you on? Is Megan on?
I'm here.
Okay, great, Megan. Okay, we're having some audio problems with some of the people that are on virtually.
If you're on virtually, please don't forget to unmute your mic in order to speak.
We're pausing to address some technical issues.
Hey, Ted, we're still in 2 different rooms, so everyone on this room is not, there's groups of folks on a different Teams meeting that can't hear anything.
How many people do you have in that room on Willie's?
It's several.
Okay, let's resend them the link.
14?
They're not using the same link. Stand by. I'll email Willie.
It's 14 people, Ted, including some of the commission members.
We are pausing the meeting until we can get the technical difficulties addressed. Oh, no, you don't want me to sing during intermission. Oh, no, 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 no. Maybe someone else here would like to demonstrate their musical talents. No one else is volunteering. Oh, shoot, we thought we had this taken care of a couple meetings ago, but.
Last meeting was flawless. So,
Yeah.
well run and everything worked.
Feel like I'm dead.
Well, by this time, after going through all this with COVID, we should.
Can you see the chat?
We will have a presentation.
Willie is sharing the link with everyone. Apparently people had two different links. The one we're on is the correct one, so she's gonna let people know.
There were lots of emails that went out. So maybe the next time you want to be sure that that doesn't happen.
No more emails. No more emails.
No, I mean, they were trying to get it, but I think that's what happened. I had like 5 or 6. So they probably logged into the 2 different rooms.
You'll get people here in person one way or another.
There you go. It's nice to see everybody. I've been saying that. I was the only one that came a few times, and then little by little, people coming. I always worry when this goes on, that people say, forget it. Gotta go do something else and not come back to the meeting. We'll see. I think that
Okay, they are now in the correct meeting room.
Let us know when we should start the meeting, commence the meeting. Started, pause. Have to get
Good
people-
morning, everyone.
Are you still in the admitting process? We're good to go? Okay, everyone. We have a little echo here we're taking care of. Okay, I think just a moment, we're taking care of the echo down here. Oops. Okay. Oh, we seem to have taken care of the echo. All right, everyone. We are now going to commence the Commission on Aging meeting. Apparently, we had people in 2 different virtual rooms, and that's what the problem was. If anyone is in the meeting now and is having any difficulty seeing us, or if you have any idea you're having a problem technically, would you please put it in chat so that the Division of Aging personnel can try to fix that problem as soon as possible. Okay, I think what I'm going to do is go back and do roll call again, because we had some of you who we could not hear your responses, even though we knew you were present. So I'm going to go back and do the roll again, because we need a quorum in order to approve minutes and to do anything else official, including election of officers. So I'm going to go through the roll call again. Margaret Smith, are you present at the meeting? Katie, you're still there?
Yeah, good morning. I'm still here.
Okay, thank you. James Gone, are you present this morning? Kelly Tungate.
Good morning, I'm here.
Oh, great. Okay, thanks, Kelly. We can hear you now. Deb Lambert is here. Dan Mustard is here. I am here. Judith Schoen, Judith, are you on?
I am.
Hi, Judith.
Morning.
Okay. Jennifer is here. Megan, are you on? Megan Springer?
Yes, I'm here.
Okay, great. Okay, we have 8 people. We're 1 person short on our quorum. So what we will do is we will file our minutes until we have a quorum. And were there any other comments, additions, corrections to those? Dan had reviewed them. Okay, we will file them for later approval when we have a quorum. We are unable to do our election of officers, and we can deal with this next meeting, but since we have election of officers in January, we may not do much with that in November. That would be, I'll put that out for consideration in November, but we'll probably just wait until January. We can't even really take action on that because we don't have a quorum. So I think we'll just probably by executive committee, if we all agree, just kind of delay that until January. Okay, we will move along with our meeting today. Then we have one of our committees here on the Commission on Aging is emergency housing, and through that they've been doing quite a bit of work. And this morning we have Doug May. Doug, I'm going to let you introduce yourself to the commission and guests. And Doug is going to talk with us. He is working with that committee, and he's going to talk with us about emergency housing for vulnerable older adults. Doug, welcome. Thank you so much for being here. If you'd introduce yourself.
Thank you. Thank you very much, Dr. Berg. I was just so delighted to see so many people here that I've known for many years, and that's good because we need some continuity. And I think the one thing I've seen over time in most human services and other programming is the difficulty of when you don't have continuity of leadership. And in fact, some of what I'll address today relates to that. But I've had the pleasure of working both with Jennifer and Deb on that committee with a group of us at Hooverwood, and I have been volunteering over the last couple of years with Hooverwood and their establishment of the Shalom Sanctuary. But going back, my background, I actually had worked for 32 years for the Area Agency on Aging here in Indianapolis, Zacoa Aging and In-Home Solutions. It was good to see Sarah here today, and I was glad to see, I'm a firm believer in the single entry point of the area agencies on aging and the work that they're engaged in. And so it was also wonderful to see Kristen Lais fighting the good fight and continuing to work with the AAAs. And I know all of you are challenged with what's coming up in managed care. But what I would like to get back to, before I retired in 2016, I was the vice president of community programs at Zacoa, but I had had a long history engaged with both care management and in my very early years in establishing what became the first elder shelter in Indiana. And in 1985, when the enabling legislation became a reality for adult protective services, there was a need to actually have investigation take place, of course, and we did that investigation. So our unit from 1985 till 1993, both under subcontracting at Zacoa and then later directly as employees of Zacoa, did adult protective services investigation. But in establishing the elder shelter in 1986, it was a cooperative venture, and I think it's very replicable. And I'm really wanting to spend some time here talking about the possible. And I think there's a lot of low-hanging fruit here, a lot of creative people, and we have some resources that are actually available. But briefly, to give you an idea of what we did in 86 it was a partnership between us at that time at the Southeast Multi-Service Center and our care management unit with the Marion County Healthcare Center. A gentleman named Jack Musker was the CEO at the time. He had asked, well, what can I do to actually help you and your investigators with the needs of people in protective services? And I said, well, we could sure use a shelter. He said, well, I think we can do that. He said, I'll talk to my board, and we will go ahead and do that. So beginning in 1986 to 1993, we served about a little over 100 people. So I would say the demand is not huge, but it all depends. I'm sure things have changed both within population awareness and other factors affecting people in need. We had a great collaboration with the IU Medical Center. At that time, Dr. Daniel Hurley, Dr. Jeff Darnell worked with our group and our team, and we established a multidisciplinary team that met first every month and then later quarterly to look at the discharge planning we did, what worked, what didn't work, et cetera. So it was very successful, and until 1993, until it wasn't. And I learned a few lessons along the way with that. And as I was told at the time, when the decision was made not to continue to have bed space at the Marion County Healthcare Center, they said, well, you know, Doug, this shelter isn't paying for itself. And I said, well, yeah, they typically don't. This is the dilemma, right? I mean, how do we find funding streams to make this work? We can't all do this out of the goodness of our own hearts. And so as I look at where this is taking place, both at Byron, with Deb Lambert, I believe your group, you've been doing some shelter services, and now Hooverwood for a little more than a year, have both relied, I think, on eventual recoupment on the per diem that they may be able to get, but not everybody ends up staying, number one, in the nursing homes they are in. And the other thing has been through fundraising. So there's been fundraising for Hooverwood. In fact, I went to their breakfast on Tuesday to do that. But my belief is that we have the tools and resources already within the system to actually expand these types of services statewide. I don't think it's a difficult task. In particularly, I think nursing homes, we have the bricks and mortar. It's here. We have not-for-profit and for-profit homes, but certainly the not-for-profit homes have a mission. And I think having a shelter really does speak to the mission. That is where we are really talking about serving people who are alive today and with us and for various reasons, are in extreme need and not safe where they were being exploited or taken advantage of, maybe not able to get the type of nutrition, other care that they need. They need something special, and it can't be a typical homeless shelter that we see, which has its own set of issues. And so I've been encouraged by a variety of possibilities, and I'll just lay out some ideas without going into great detail because they're all very debatable. But as I look at one way of doing some of the other funding that could be possible for willing partners in this, in the state of Indiana, most nursing homes are now owned through public ownership. And I'll give the example here in Marion County, with Marion County operating through the health department, 79 nursing homes, which operate statewide in every corner of the state. I know that our nursing homes in Indiana continue, unless something's radically changed, to be underutilized. We're overbedded. And so several opportunities, I think, would arise. We were able to build Eskenazi Hospital here, which I'm grateful for, terribly needed with, as I understand, many of those funds that has made it so attractive for public entities to purchase nursing homes. So that's one area. I'm sure that money has been spoken for by many people many times, and many different ideas of using that. I know that we are now moving into a managed care system. And I would say that many of the people that end up in emergency housing or in the type of housing we're talking about that is needed are often in hospitals and are in more expensive care. And some of those folks do not meet level of care. And the fact that they don't meet level of care would mean, again, the nursing home right now doesn't have a means of recouping its expenses. But I think through managed care, as that is developed, that could be another source. But I've been more encouraged in doing my homework today. And that is that I did get, and was aware, let me back up a little bit, that Indiana, you may be aware, received $1.6 million for adult protective services for its enhancement for a 2-year period with possible extensions of that. And there is a plan that was developed that honestly I just came across yesterday afternoon, late in the day, that tells me exactly the fact that we've put away for emergency services in APS $50,000 for 2022, but then it jumps to $202,500 in 2023, the same period, and another $202,500 in 2023, and then another total of $112,500 for those services, and specified what was interesting to me in this plan that was written December 21st of 2021. In the fourth goal for service delivery, there are 4 total goals in this plan for program improvement. It says increase the availability of emergency services by assisting Hooverwood and identifying and contracting with additional vendors to provide services in geographic areas of greatest need. So I am grateful. There appears to be money here and available. And this plan, I wasn't able to find it on the FSSA site. It may be there, but I found this on the ACL site, and it gives the plans for every state along with budget sheets. So this is encouraging, and I think the will is there. I think that's the other thing I wanted to say. I think that a lot of people see this need, and if I were, working and running a nursing home right now, this might be another payer source over time to develop, and I think a very appropriate one. I want to circle back and get into what happens to people, however, after they have been in a shelter of this type and need further services. Right now, we really don't have a mechanism to begin to get care managers or a care management system working really for anyone in APS who does not need some of the other basic services of a Medicaid waiver or the choice program. So, again, whether it be through managed care or I'm leaving a lot open here because I think that discharge planning and connecting with the care manager is extremely important. Right now, APS has been left with very few options for what they're able to do. And if I would back up at all in this, I would say that for many reasons, adult protective services always has been almost not the best terms, but a stepchild in aging services. And a lot of it may have to do with the model itself, because we have a direction and funding coming out of FSSA and the Division in Aging to fund the prosecutorial units. But once that money is passed through, and because it's kind of always been a lost leader, so to speak, we don't give sufficient funding to begin with to get the job done in the field that's needed. And so, the prosecutors have a lot of leverage in this and how they do and what they do. I've known that there have been investigators who really don't see a connection at all to FSSA and state adult protective services. So we really still have quite a hodgepodge system, and just not backing up, but I did want to mention that grant that I mentioned, that is a part of the Adult Protective Services operational plan, has $250,000 allocated for an assessment of protective services as a whole. And it was looking at individual units and teams. And in my comments here is that I hope that we'll also look at that elephant in the room, which is the system itself. What do we need to actually change? What would be the best way of operating this in Indiana? But I think anybody who does organizational analysis would say that this is not made to function well. It just is not a design in and of itself that allows us to achieve, I think, many of the goals that we are all hoping to achieve and planning to do. So I guess to recap, my vision, for what it's worth, is that we have the capacity in Indiana now, we have the bricks and mortar there now in our nursing homes. It would be relatively easy, I think, to create some standards, guidelines for how they operate, and probably have an MOU of sorts with each APS unit. But nursing homes could themselves become certified, in effect, to be a protective services provider. It could be very low key. This is not something that is going to take up thousands of beds, in my opinion. But at the same time, for those who are facing, and your investigators could sure tell the story better than me, but for the folks who are facing the need for this type of housing, making these changes and improvements would be very good for Indiana. And as a side note, I thought it was interesting when this grant went out to the states, that its very first priority was establishing or enhancing the availability for elder shelters and other emergency short-term housing and accompanying wraparound services for APS clients. So that was the lead allowable task. And it's good that we have some money there. I think there's probably a lot of wiggle room in here within that plan. And I think we have people in this room who can help address some of the issues to make this work. Two other things I wanted to mention that I did forget to mention that for the last 3 years, I've been on the board for the Center for At-Risk Elders. And now I guess I'm the board chair, but it is a not-for-profit public interest law firm that certainly engages in guardianships, public guardianships, and often encounters the very types of people who may end up in shelters, and the need for good public guardianship services that extend beyond simply establishing the guardianship and having someone placed in a nursing home is also needed in the state. And I think that the Center for At-Risk Elders provides a good model. We've been around for about 10 years and have worked with hospitals and contracting to establish that. And the other thing I forgot to acknowledge while I was acknowledging some of the people in the room and some of the people I've known and worked with, I see Kelly Tungate, or I don't see you, Kelly, but I'm glad you're here. Both, I think I knew Kelly when you first came to SEQOA as a teenager almost, and later worked with and for Kelly, and it's good to see you here. So anyway, I think I've made some of my more hopefully salient points, and I'd like some discussion and to get into some other ideas. My gripes, by the way, with APS are never personal. I really feel for the people who've been in those positions and what they've had to do. And I knew once I started getting back engaged with this over the last several years, I just saw that we have, again, That was an interim position for a long time, the head of Adult Protective Services. It was vacant for a long time. You know, I'm glad to see actually in this operational plan, there's some operational funds allocated for the state unit itself, if I read it correctly. That's needed. So I have, like I say, great admiration for all, especially, you know, you have some really wonderful investigators out there. Not all, but the ones that you do are really dedicated individuals, and I can certainly attest to that in Marion County, having worked with some of that team there, and particularly Mary Ledford and Andrea Kosala. We're lucky to have this job and this work done. So I don't think it's a budget buster by any means. I think the monies are there, and we have models to follow. And lastly, I just say that this helps build a network. We don't really have a strong advocacy network that really supports adult protective services and some of the related services. And actually establishing these shelters with multidisciplinary teams begins to do that. It begins to get people talking to each other. And that's just it. I firmly believe in collaboration, low-hanging fruit, you know, grab some victories where you can. I would simply say, you know, a really small victory here would be, I looked at that at Indiana Adult Protective Services unit map and see it's not changed in the years that I've been there. And the problem with that is its whole taxonomy. And a director I will not name, probably 25 years back, joked, and he just said, you know, yeah, I'm running this, but I don't have any services, and they can't even name my units right. So my point is, you have 1 and you have 1A, and then you got unit 8 and no 8A, but you got an 8B. Oh, there is no unit 9. But then you go down, there is a 13A and a 13B. This is very small stuff, but frankly, it's just one of those things that would be easy to change and get right. And you're not going to upset any apple cart that I can see to at least get something that makes a little more sense in that way. But very small point. I'll be quiet now. I'm open for thoughts, questions, discussion.
How would you define a shelter for older adults? I mean, what does that look like? And is there a variety of models that people could?
There are a variety of models, and probably the best place to look at different models is the Weinstein Center on Elder Justice out of New York. Freestanding does exist, and it's not what I'm suggesting. What I'm looking at, I think, is first and foremost safe, secure space. And usually most of the shelters have looked more like whatever nursing facility they are in. I would like, you know, I'm certainly have all been for whether it be the Eden ideas and other ideas of changing how we work in nursing homes as well. But right now it would have some institutional appearance to it. But it would be ideally individual rooms and somewhere to, it's not something where you go down the hall and this says elder shelter.
I think the ideal shelter in my mind, and that's what the neat thing of this committee is we all have kind of different visions. But from what I'm learning by spending some time talking to the APS folks is they have a lot of people that they need to pull out of some bad situations, but they have nowhere to put them. So I would see kind of long-term care and assisted living being more of a touch point to get them out of an immediate bad situation so that a full assessment can be done. And then I would hope that most of those folks could go to a different situation. There are some that would need maybe to stay, but the hope would be that that would not be the vast majority. So it's getting them away from the immediate negative situation, whether that's a physical structure, whether that's family members, and then finding a different physical structure for them to live in, or better family members to help oversee their care. So I don't see the long-term care part. I just think that, like he said, our buildings are everywhere throughout the state. So, you know, getting this program rolled out in a couple of different counties and kind of tweaking it and then rolling it out in all counties, it just makes sense to have the long-term care assisted living kind of be that immediate touch point that would just be kind of an opportunity for case management to come in, bring supportive services and get them into the least restrictive environment.
Exactly. Yeah, and to me, it is that piece that we really need to get, and it seems to fit very well within the AAA's functions to be able to do that type of care management, perhaps IPMG too.
Is there any potential for a type of foster care system for older adults that would be very temporary, but getting folks into, especially if a person is not necessarily meeting level of care for a nursing home, but it's not safe for them to be alone, for folks to be able to.
I'll leave that, and Deb, you may have some ideas too. I'm not sure. Sure on that. I mean, I like the concept, but I don't know.
Yeah, I think we're going to have to look at a lot of different solutions. For this hot minute, I may be in the minority when I say I'm very concerned about the very aggressive pace with which we're moving to manage Medicaid. People who are predators go to places that they know they can find their prey. And I think if we don't do some of the home and community-based services very carefully, our opportunity to have the need for adult protective services rapidly expand is very real. Like I said, I may be the only one that believes that, but I've been doing this for 25 years, and there's a reason that I believe what I believe. I've seen a lot in 25 years. So I think we should, like I said, everything is on the table. I think looking at every option, I think adult foster care is a very interesting idea and something that could definitely be looked at. But we haven't really eliminated anything at this point. We're trying to bring as many people into the tent as we can to provide as many safe solutions that we can provide.
I'm sorry, I might have missed, but how many people per year are we kind of looking at currently that utilize this emergency placement?
We're not talking about big numbers. When we operated from 86 to 93, we did a little over 100 people. So that was Marion County. Now, yeah, I'm ancient, so that goes back a ways, but now I would, so again, I don't think the numbers are overwhelming. I think there's some national studies to look at too.
Well, and we're actually, as part of our committee, we're putting a survey together to send out to the APS folks to get an idea of what that's going to be. And quite honestly, I know our focus here is on seniors and APS, emergency placement, but the reality is I just took an emergency placement for an 18-year-old. So the need is larger than just seniors. And in my opinion, if we're going to solve a problem, let's solve a problem. So I don't know. We're looking to solve a problem.
Right. And, yeah, I couldn't agree more that we've got to deal with that younger population, and that may have some other numbers. Looked like you had another question.
I do. As far as I'm sorry, kind of going back to the home and community-based services, where are we seeing most of these APS emergency placements coming from? Is it mostly by case managers calling in? Is it a lot of home care calling it in? Is it hospitals or doctors, or is it just completely random?
Let me speak for Hooverwood, and you can talk about your experiences there, Deb. That so far, most of ours have come directly from the Adult Protective Services investigator.
Okay.
So that's where most of the referrals have come from.
Yeah, so the answer is yes. I think they come from all those areas. They get directed to Adult Protective Services, then who becomes the hub of that.
Okay.
But I do think they come, they come from APS to the hospital. They come from the hospital to APS. So it's,
Okay.
the
I
road
just-
heads both directions.
I think I kind of have a concern. I'm in the home and community-based services. We do home health. And so we are in places, we're in people's homes. We're, and eyes and ears in people's homes, these elderly people. I mean, and we have quite a few disabled people, but we're in the homes. I do have concerns with the managed care system and where we already are with census in our elder population getting care versus people that are eligible to get the care, having less eyes on people and less ability to report, because I know in home health a lot of reports do come from there, but as staffing goes down and people are able to not get this service, how many more cases are just going to be missed is I guess my concern.
Yes, that's what frightens me as well. It's going to happen. And it's going to get worse as we shift our focus. So that's my opinion.
Anyone else?
Well, I always come up with questions, and I hope other people have more questions and comments, because I think you've laid out very well that this is not an issue that's going away.
No, and we can do something, right?
And I think you also, funding's always a big question. And I think you laid out some ideas for where there may be some money. And it looks like probably, if I heard you correctly, probably some of the lowest hanging fruit is already in the grant that
Right.
the ACL has already discussed.
Yeah,
We
this is,
haven't brought it to Indiana to see what that would look like. We're kind of asking that gets looked at, am I correct?
but
With the
Indiana's,
DA, I just thought I'd say that.
Indiana's plan is laid out fairly well with the money. So yes, we've got some money, I think, to start with.
I think you
beyond that.
also have added, if I heard correctly, I don't know how to say this, except I guess I'd say in the MLTSS plan, one would anticipate there would be some of this showing up there in their hospitals, et cetera. And so, but those people would already be under Medicaid. So I think the population you're talking about probably isn't served by the AAAs. Well, they may be, but I doubt it.
Well, the one I took in, the 18-year-olds Medicaid.
Already on Medicaid.
Yeah, I think a lot of the folks may qualify for Medicaid. The real question is, what percent of this population really needs long-term care in a facility? Will they meet level of care or not?
Okay. And then the other funding source that you mentioned that I'm going to venture into, although it's definitely probably not the lowest hanging fruit, is the upper payment limits, which, well, Indiana, now this is my limited understanding of this, but I think I'm glad you brought this to our attention, because my understanding is as we move to manage long-term services and supports, some of that upper payment limit is, some of the issues around that may change if funding cannot go to hospitals and it goes directly to nursing homes. And we have some venture capitalists who have been buying distressed nursing homes, charging very high rents now after they get low interest loans. And this could be an issue where there's money that would be going for high rents. That's out there, and there's quite a lot of money. So while we're in, and that will be highly contentious, I understand that, but there's money there, and it's money that is earmarked to go to people who are vulnerable. So I think that just needs to be, we need to underscore that and know that's there, and it's an issue.
And right now with the MLTSS, what they're proposing is that they're going to take part of that upper payment limit and do a set aside based on quality. So if the state's going to have a set aside, then there may or may not, I don't know how far down the track the train is right now, but I think if there's an opportunity to try to get some money from that situation, it would be probably through a little bit of a set aside through that quality money that they pull out on the front end of the payment source, but I don't know.
I just want to add in, can I add something on that? I've spoken to quite a few providers that are looking at this managed care coming down the line, and that is one of their main concerns is this quality set aside, that funding is already so low that they are not sure that they will continue to take the managed care as a service. So that is one of the concerns that was put forward. I just wanted to, as you pointed that out, I wanted to add that in, that probably needs to be looked at and addressed, because that puts us at even less people being served.
Thank you. Other thoughts, concerns, questions?
Joanne, this is Judy. You said that there was a plan out there for the state of Indiana. Where can I find that?
Yes, if you go to the ACL website, that's where I got it. It's Adult Protective Services Operational Plan. It's a 16-page document. It was originally filed in December of 2021. And, but yeah, the administration for what, community living, is that right? ACL.
And
Thank
I
you.
believe there will be more about some of this in the DA update today.
I'm sorry, will be where?
Love you. DA. Oh, you're going to send it out. Okay, Aaron is going to send out the information that Doug is referring to, Judith.
Thank you, Erin.
Well, and, you know, since we're kind of on this topic for a long time, I'll just throw my update in here as well. So something that we're looking at as a committee is to find public-private partnership funding. So I've been talking to the hospital in our area, and quite frankly, they're doing a cost analysis right now on people who are sitting in their beds in the hospital that don't need to be there, but they can't find a place to discharge them. That includes Medicare folks, but it also includes people that don't need Medicare services but don't have anywhere else to go. And so what they're finding is it's very costly for the hospitals to have someone occupying a bed that doesn't clinically need that bed. So we're trying to work with a not-for-profit hospital in our area to fund through their foundation emergency shelter money. So that's something that we're, you know, it's one of those win-wins, right?
Right.
So that's something that we're working on, and I'm not going to say we're far down that path, but I'm very encouraged by where that path is going.
Mm-hmm. I think there's some of those high-cost folks that are in hospitals for whom these types of options really could fit. And every time they do, they're a huge cost saver when it does happen. So I'm glad they're studying that and doing that. I like that.
That's our update.
We're
All
getting
right.
a little busy.
Thank you.
So thank you so much, Doug, for your very thorough and you gave us some positive direction on this, some ways to begin to address it. And Deb, your work on the committee, I think you just gave us your update on the emergency housing committee that's working. That is a committee of the Commission on Aging. This is not going away. We will continue to be following and have you do updates each meeting so that we can follow this, because as Indiana is making some rather vast changes for services for older adults, this certainly is an area we do not want to lose sight of as we move on. So thank you so much. Appreciate it. Okay, now we have an update from the Division of Aging. I don't know who's doing the update. Okay.
We do have slides. They're a little small up there.
The slides, okay, they should be up. If you can't see them, please let me know and I'll see what I can do on my end.
We can see them, they're just small on the screen. I don't know if there's a way. So
I have it.
everyone virtual. Oh, I'm sorry, go ahead.
So it's full screen on my side, so I don't know if
Yeah,
you
I
can
think
make
it's
this.
our display.
Okay.
Yeah, so, and we do have some pounding occurring unfortunately, so sorry if you all can hear that. So I'm gonna plow through if everybody is okay with that. So I apologize for the in-person folks. We'll see if we can get that expanded. We will circulate the slides afterwards, so you guys can have a full picture of them if you can't see that. So wanted to provide just some key updates today on some different Division of Aging initiatives. Like I said, Aaron, Wright, and I will sort of share the load here, but I'm going to do the first chunk here. I'm going to, Rebecca, if you want to move to the next slide. I'll do, and again, I know it's small for the in-person folks. So I'm going to give an update on the LTSS reform project. I'll run through the key results and some key updates there. I will touch on MLTSS procurement status, and then wanted to touch on the enrollment services vendor RFP that is also out for bid right now. And in that, I will cover some information about the AAA's role in MLTSS, because I know there were some questions on that out there as well. Aaron will do an overview of the AAAs and the other things we're partnering on with them outside of waiver work. So Older Americans Act, Choice, and SSBG. We're at the end of the federal fiscal year, and just thought it would be a good time to do a refresher on that too. And then I will give just a really brief preview on some of the other Division of Aging initiatives that we're working on now and kicking off now. So there are quite a few slides. I'm going to run through most of them fairly quickly, just in the interest of time. And also some of it is mostly so you guys have this for reference. So like I said, we will circulate the slides around, but wanted to at least make sure you guys had that information available to you for future reference. So this first slide, and again, I know the folks in person can't see it, so I'll read off a lot of this. So this is the big picture overview of the LTSS reform project. So this does include MLTSS, but it has all of our key results encompassed in one project. And so the ultimate goal of this project is for 75% of new LTSS members will live and receive services in a home and community-based setting. That's based on lots of information that we've heard over the years that folks would prefer to age in their homes and not in an institutional setting. And so we want to make that a reality here in Indiana as much as possible. And then the second key objective is that 50% of our LTSS spend will be on home and community-based services. I think we all know that that's not the case today. And so the goal is to reach that objective as well through this project. So the way that we plan to do that is through 5 key results. The first one is getting access to home and community-based services within 72 hours. The second one is moving LTSS to a managed care model. The third one is linking provider payments to member outcomes, or what's also called value-based purchasing. The fourth one is integrating all of our data systems to be able to link individuals, providers, and facilities in the state. And then the fifth one is our direct support workforce and setting up a more robust system that allows for the recruitment, retention, and training of a direct service workforce. So big goals. So we do have on the next slide, the quality framework that are really our guiding principles for this. So there are 3 items here: person-centered being first, and obviously very important, ensuring smooth transitions, and access to services and participant choice. So again, I'm not gonna read this whole slide, but there are some additional details in there that you can look through when we circulate those after the meeting. So the next slide is on our first key result, that ensuring Hoosiers have access to home and community-based services within 72 hours. The way we are going to achieve that is through expedited waiver eligibility. So we did kick off a pilot for that in 2020. So far, we have approved over 4,100 applications through that process. Right now, we're operating it under Federal Public Health Emergency Authority. So we're working with CMS to create permanent authority that will allow us to make that pilot statewide and permanent. But so far, we've seen really positive results from that. So the next slide is our MLTSS timeline. So I wanted you guys to just have the visual of what this timeline looks like for the MLTSS rollout. So right now, the green square there is we're in the competitive bid process. It is out for bid right now. So there is a limit to what I can talk about today for MLTSS because it is out for bid. So I'll talk about what I can. If I can't answer something, or if I'm not sure that I can answer something under our IDOA policies for procurement, I'm happy to take things back and then follow up with whatever information we can share. There is a lot of information on IDOA's website, certainly the RFP and all the supporting documents that I think lots and lots of pages, but lots of details in there too. The goal is, so the bids are due, I believe, by the 22nd or 23rd of this month. We'll have a couple months of the RFP evaluation process, and then the awards will be announced in Q1 2023. We will then have essentially that full calendar year of 2023 to do readiness review and implementation work so that MLTSS will go live in Q1 2024. So in early 2023 is when the bid awardees will be announced and when that information will be made public. So the next key result, value-based purchasing. So that objective is linking provider payments to member outcomes. A lot of this is in information gathering mode and analysis right now. So CMS did release their first ever HCBS quality measures in July. So we're reviewing that and then reviewing some planned surveys and other metrics to help us define value-based purchasing quality goals as a guide. And we're also engaging with some national expertise on that too. The next item, or KR4, is the data integration. And so as you can imagine, we've got lots of different systems. They're fairly fragmented and siloed. And so thought it's really important to have a KR focus on integrating all of that data. Right now, they're working on developing a surveillance plan and working to map out measures to data sources. And then the fifth KR is that direct service workforce key results. So I think we all know that if we don't have people to do the work and provide the services, then this isn't going to work. So this is a really important KR. Obviously, Peggy Welch, our Chief Advocacy Officer, is spearheading this KR work for us. She is working with the Bowen Center to engage and put together a plan for the state of Indiana focused on how we can better recruit and train and retain and support those direct service workers. We did most recently have a full day session in late July to get stakeholder input and engagement. I know lots of you guys were there for that session, so appreciate folks that were able to be there and participate. We'll have more to come on this one soon. These next couple of slides are not official key results, but they are really important for the work that we're doing. So wanted to highlight just some of these pieces that are integrated into the LTSS project. So Medicaid finance, it is a key result. It just doesn't have an official number, but the point of this one is to strategically transition our current fee-for-service reimbursement structure to drive quality, alignment, transparency, and sustainability, and provide forward compatibility with managed care. So really taking a look at our finance and reimbursement structure and how we can make that work a little better for the state. So most recently, they did form a steering committee composed of some different stakeholder groups like Leading Age, HOPE, IHCA, and IHA. And they are looking at updating various things tied to the quality assessment fee, the UPL program, and quality metrics to include in the UPL program as well. So that is part of that work group. And there are some guiding principles listed there at the bottom, which I won't go into, but again, just provide some framework for how we're approaching that work too. The next item is probably somewhat familiar to you all because I know Dr. Council has presented fairly recently on some of the work they're doing for the dual eligible population, dual eligible being individuals who are eligible for both Medicare and Medicaid. So I'm not going to go into a lot of detail here, but the focus is certainly increasing coordination for dual eligible individuals. And so I know Dr. Council will be happy to provide another update at a future meeting too on some of that work. And then this last piece, self-direction. So some of the feedback we did get from consumers was that we need to think a little differently about the way we're approaching self-direction. And so right now it is primarily under our A&D waiver, but they're a little smaller in scope. And so we are creating a new waiver called a J waiver that will allow us to redesign and expand self-direction under the waiver services as well. So this next slide is enrollment services and member support services. So we do have out for bid right now an RFP with 2 different scopes of work. We've called it the enrollment services vendor RFP. The first scope is tied to that front end enrollment services work. So level of care and PASSR and options counseling and Medicaid application assistance. So that's one scope of work that's out for bid. And then there's a second scope of work under that same RFP for what is called member support services. The feedback we had received was that it's really important to have an entity that is there to support members in MLTSS to ensure that they receive the services that they're entitled to be receiving. It's an ombudsman-like program. We have not called it ombudsman because we don't want it to get confused with the long-term care ombudsman program, but they are similar in spirit. So this member support services scope of work will include assisting members with understanding their MLTSS plans, supporting members in grievances and appeals, and also assisting us in FSA to spot trends and make sure we're on top of any issues that are occurring so that we are able to resolve those issues. So that one, again, is out for bid right now, and we'll have the evaluation process kick off here in the coming weeks.
So is that going to be in addition to case management or an
Yes,
add-on to the case?
in addition to case management. Mm-hmm.
Okay.
Yep. So next couple of slides talk about the role of the AAAs in MLTSS. So under MLTSS, they'll have a few options in how to engage with individuals. So this first slide covers the front end option, so intake and eligibility. So essentially that enrollment services vendor that I just spoke about. So the AAA, so a single AAA or a network that includes other community-based organizations could either submit a response directly to that enrollment services vendor RFP, or they could choose to subcontract with whoever wins that enrollment services RFP in order to provide level of care work and that intake counseling or the member support services work. So that's one option. On the next slide, we talk a little bit about the back end. So this is post-enrollment. So after that intake and eligibility work, this is case management essentially. So under MLTSS, the managed care entities will be responsible for what's called care coordination, which is essentially case management. And so AAAs may choose to subcontract with the MCEs and provide care coordination for any of the MCEs. We did build into the MLTSS RFP that for the first 2 years, the MCEs, whoever wins the bids, must contract for at least 50% of their HCBS case management work with a current entity providing those case management services, which is by and large the AAAs, though we do have a couple independent case management organizations. So that 50% is the floor, not the ceiling. We'll certainly encourage them to have as robust of a relationship there as possible. So that is sort of that second option, is that care coordination, case management, subcontracting work. Yes.
And is it an either, they can't do both, it's one or the other?
Correct. So that's the next slide, actually. So thank you for that nice segue. So the reason I refer to it as options is because, yes, it is an either or essentially. And so the feedback we heard over time from a variety of stakeholders was that whoever is doing that enrollment services work needs to be independent from the MCEs and should not have a relationship with the MCEs. So any entity that is doing that enrollment services work cannot have a financial relationship with the MCEs. So AAAs will have the option to decide for themselves, looking at their own business structure, what their strengths are, and determine if they prefer to do the case management work or if they would like to engage in the enrollment services side of the work. Any questions on any of that?
Leslie, can you clarify for me, for the enrollment services, is that for the population up to age 60, or is it anyone regardless of age?
Anyone regardless of age.
Okay, thank you.
You're welcome.
What are the areas that you're doing your 48 to whatever, 36, 48 hour, like,
The expedited waiver eligibility. We're partnering with a couple of AAAs on that right now. I don't recall off the top of my head. I think Sequoia might be one.
I think there might be up to 5 or 6, actually. I got a couple in Northern Indiana, Sequoia, might include all 3 over the top of the state, Sequoia, Jenny, Fleischking, and then I believe Fleischking Resources in southeastern Indiana.
We can send that out as follow-up for folks on the screen that may not have heard that. Kristen mentioned that there are several, probably 5 or 6, including a lot across the top of the state. So, but we can share more specifics on that.
I have a question
and
on.
then okay, go ahead. I'm sorry.
I have a question on the 72 hours. So as far as that just is getting people eligible to receive the service, but that doesn't necessarily mean within 72 hours they have someone coming out, right?
Our ultimate goal is within 72 hours, they will have someone coming out. Today, the pilot, yes, I mean, it's focused on that eligibility process, but ultimately the goal is that we'll be able to link them to actual services within that time frame.
Okay, and get them actually started.
Yes.
Okay. I don't know how tied in together these plans are, but that with the staffing issue, having staff available to start within that time frame, has that in the pilot program, has that been successful, or is that kind of a struggling point?
It's definitely something we need to continue to work on. So they are, the way the objective and key result structure works is you have your objectives and all of the key results essentially integrate together to feed up to those objectives. So if our goal is we're going to get folks, we're going to allow them to be able to reside at home and get them services as soon as possible, that staffing work that we're doing will feed into some of the other work that we're doing, and they should braid together to get us where we need to get. But yes, I mean, because we're still in the midst of doing the work on the direct service workforce piece, there's still work that needs to be done to hit that goal and have folks connected to services as soon as they're eligible.
Okay.
So how long has that pilot program been going on for now? And then like, when will we be getting like a summary of what you're seeing, you know, to her point? Like, I presume you are tracking how many hours, and once somebody does get admitted into that how many hours until they actually see a human being with that supportive services.
So we've been operating the pilot since October 2020. We can certainly provide an update at one of the upcoming meetings on that, on the expedited waiver eligibility piece specifically, if you guys would like to have more information. Some challenges we faced on data collection is because of the maintenance of eligibility requirements. We're still working out ways to evaluate accuracy of the EWE process and all of those things, but I know we've got some data that we've been collecting to evaluate, so we can share that.
Yeah, I mean, if you've got your data put together where it's like year over year, I mean, I'd like to see like, are the trends getting better, or, you know, staying flat, or are they doing? So yeah, it'd be, you know, I'm a numbers nerd. That'd be fun to see.
I do have one more slide before I hand off to Erin. So I did want to highlight as well some upcoming engagement opportunities. So we are kicking off what we're calling stakeholder engagement 4.0 for co-design. So we've had lots and lots of stakeholder engagement sessions over the last couple of years through this project. And so we are kicking off the next round next week. If you are interested in participating and you're not on that list, reach out and let us know, and we're happy to connect you with this team doing this work. But so there are several co-design meetings coming up over the next several weeks for that. And then another piece we're really excited about, we're partnering with Advancing States to hold in-person community conversations all around the state in late September and early October, specifically targeted at connecting with members and caregivers, and then providers in separate sessions, but to get direct feedback from members and caregivers and from providers on what their concerns are, what they want to hear about, what questions they have with all of this. So I've put up here on the slides the dates and general locations, but we do have flyers that we can circulate and would really appreciate folks promoting these sessions as much as possible. It's really important for us that we get as many folks participating as possible and get as much feedback as we can. So when we send the slides out, we'll send out some of those flyers too. And again, would appreciate folks distributing far and wide as much as you can to help us out with that. Does anybody have any other? Yeah.
The co-design meetings, are those, that is what you're talking about, the stakeholder involvement?
Yes, so there's the co-design meetings, those are the stakeholder involvement, and then the advancing states meetings are for caregivers and members, and then there will be separate provider specific sessions as well.
You said that information of who to contact if you're interested in being part of that's
Yep.
on that slide.
It's the Back Home Indiana email box, and it's on there. Yep.
Okay. Yeah. And we'll get those emails.
Yes. Yep. We will get those.
I have another question that I wrote down as you were speaking on those key points. The value-based purchasing, I know you said that it's going to go through, you're working with quite a few different places to put those together. And I know in Medicare, we take Medicare, so it's based on outcomes, whether, you know, someone comes out of surgery and is able to, you know, walk around their house and, you know, be independent after that 60 days. With the Medicaid population, it's more chronic cases. So is that not going to be part of the quality base? Is that exempt from it? Because I don't see a lot of these chronic cases improving. In fact, I mean,
that's
conditions will go down.
That's a great question. I do not know the answer to that. So I'm happy to take that back though, and we can follow up with some additional information on some of the details. I know, like I said, I know a lot of this piece is still sort of in the early analysis stages. So I don't believe we've made any key decisions on how that's going to function yet, but we'll follow up with our BVP team and get some additional details on what.
Okay, that'd be great. Thank you.
Yep.
Do you have a time frame when you anticipate that coming out? I'm just thinking about, for planning purposes for organizations and companies and who want to gear up for this and be prepared for it, the lack of financial info is really concerning. Like, how do you prepare as a company to expand your workforce and be prepared for this if you have no idea what dollars are coming with it?
Are you referencing the value-based purchasing piece specifically, or
And rates.
And rates? I don't have a specific timeline. Again, we can follow up and provide more details on that. I know with the finance key result piece, we're working to move that along fairly rapidly if we can, just because I think we want to be able to provide that clarity as soon as possible. We're going into a budget session, so certainly that has an impact on certain things as well. So I know they're trying to ramp up pretty quickly with some of that.
I have a question, and since I'm not a provider, I'm just going to be asking a question as someone from the general public. The services that are listed under, and I know you can't answer some of this, but this I think you can answer, under managed care. Am I correct in saying assisted living, adult day services could be services that are covered but not required under the managed care service menu?
No. So if it's a waiver service today, then it will continue to be a service available to folks that are eligible for waiver services under MLTSS.
Okay, so it will be a waiver service available to them. It's not part of the menu for ML.
It is part of the menu, yes. It is part of the menu for MLTSS. It will still be a waiver service through MLTSS.
Okay, all right, just clarifying that piece. However, one other piece here, I think we talked about housing and the issue with older adults, the number of older adults probably struggling with affordable housing right now. It's probably not going to get better. Group homes is not part of a plan in Indiana. I'm thinking of group homes in Michigan, for example. Indiana does not have that in its plan.
For older adults specifically? Yeah. Okay. I mean, that's something I'd have to look into a little bit. I know our framework for group homes and supported group living is a little different than some other states. I know a little bit more about that on the intellectual and developmental disability side than for seniors specifically, but can certainly look into that a little bit.
Yeah, I mean, I am also kind of tying that back to our earlier discussion. We may have some people who, when they get discharged from the shelter, if they don't need nursing home care, I don't know that we are going to have a lot of options, but I think that's a hole in Indiana with our services. I'm just kind of bringing that out as Indiana is looking to make a lot of changes here. I think that was passed over to have, but what I hope we don't have are a number of unlicensed boarding houses. So that's why I bring that up.
With that, if there are no other questions for me, I will hand it over to Erin. Oh, yes. So, so for those folks that do participate in those in-person community conversation listening sessions, there will be gift cards available for participants as well. So a little extra incentive for folks to show up and share their thoughts with us.
Thank you, Leslie.
Okay, as Leslie mentioned, I'm going to spend some time talking about AAAs and really kind of going back to the basics of the aging network in Indiana and the roles and responsibilities of the AAAs as outlined in statute. So I'm really going to be focusing on statute. Some of you are very familiar with this, particularly those in this room, so bear with me. Others may not know some of these details. So we really wanted to level set and ensure we all have a foundational understanding of these statutes and roles for the AAAs as outlined in them. So the foundation and core responsibilities of an entity designated as an area agency on aging is rooted in the Older Americans Act. And the Older Americans Act is federal legislation passed in 1965 at the same time as Medicare and Medicaid, and it was recently reauthorized in March of 2020. So the Older Americans Act created the Aging Network, which is a network of home and community-based services that serve as a critical component of long-term services and supports, not only in Indiana, but across the country. So Indiana receives funding in various buckets that must be used for services that fit into those buckets that are called titles. I know you can't see here in the room what the different buckets are. There are 6 of them. There's Title 3B, which are services that enable older persons to live independently, whether it's transportation, care management, in-home personal care services, support for senior centers. There's Title 3C, which are the nutrition services, congregate meals, home delivered meal program, nutrition education, nutrition counseling. Title 3D, evidence-based health promotion programming. 3E is the National Family Caregiver Support Program. Title 7 is the Ombudsman Program, and then there's another title under the Older Americans Act, which is the Senior Community Service Employment Program. Title 5, which is actually not part of aging. That program is administered through the Department of Workforce Development here in Indiana. So under the Older Americans Act, all of those buckets of funding must go to specific designated agencies. And the Division of Aging, as the state unit on aging, Rebecca, you can go to the next. Thank you. Designates local public or private nonprofit agencies to address the needs and concerns of older adults in a specific geographic area. Excuse me. And these are the area agencies on aging. So AAAs, as you know, coordinate and offer services that help older adults remain in their homes And by making a whole range of supports available, AAAs make it possible for older individuals to choose the services and living arrangements that suit them best. So the funding in the various titles or funding buckets is distributed through a population-based funding formula that we have to receive approval from the administration for community living. And that's part of our state plan on aging. And actually just last night, we got approval for our 2023-2026 state plan on aging that we've been working on over the next year. So I'm super excited that that happened and we can check that off the list. So similar to the state submitting our state plan on aging, the AAAs must submit and implement an area plan on aging. And this is outlined in the Older Americans Act statute. In Indiana, we have a 2-year cycle for area plans. The current plans are for federal fiscal year 2022 through 2023. And federal 23 is going to start here in a couple weeks. So the AAAs will be submitting their next round of plans before the end of the state fiscal year, so June of 23. And for those of you who've been on the commission, you have a role in the review of those plans. So we'll be working on that next summer. So through the area plan, the AAAs provide a number of assurances for how they will fulfill their responsibilities under the Older Americans Act. And language on this, which you can't see, and the next several slides is taken from the statute, the federal statute, and highlights some, but not all of the key concepts. So I'll go through them pretty quickly. But the AAAs must provide through a comprehensive and coordinated system for a variety of services within their designated counties. The AAAs are charged with understanding the needs of the older adults and caregivers in their community and making sure that they gather input from those that they serve under their plans. The AAAs are required to ensure that a certain proportion of their funding is expended in specific service categories. There has to be a certain percentage associated with funding to access to services, funding to in-home services, and then legal assistance. Next slide, I think. The AAAs serve as an advocate and a focal point for older individuals within the communities, and they designate focal points in each of their counties to serve as a location where individuals can turn for information and support and access to services. They also establish an advisory council of older individuals who are either participants in their Older Americans Act funded programs or are eligible to participate. Next, a really key role of the AAAs involves outreach to identify individuals eligible for Older Americans Act assistance, with special emphasis on a number of different demographic groups, those with greatest economic need, those with the greatest social need, older adults with severe disabilities, limited English proficiency, those with Alzheimer's and related disorders, and the caregivers of those individuals, as well as those at risk for institutional placement. Through this outreach, the AAAs are also charged to not only identify them, but also to inform them of the availability of programs and services. So along with this, through their area plans, the AAAs set specific objectives for providing services to older adults with the greatest social need, economic need, and at risk for institutional placement. And the Older Americans Act requires that there be specific objectives really for targeting low-income minority populations, those with limited English proficiency, and those in rural areas. So in addition to these requirements that are in the federal statute, and as I mentioned, that wasn't everything, those are just some key points. There are requirements for the AAAs outlined in state statutes specifically related to the choice program. One that statute outlines case management as a service conducted locally by the AAAs for choice, and two, the statute references the management and operation of the choice program locally through the AAAs. So on the next slide, there's just an overview of the funding that the AAAs receive on an annual basis through grants to fulfill these requirements. And this is specifically focused on their non-Medicaid related programming. In total, there's about $63 million a year. And again, it's divvied up based on that approved interstate funding formula. So it's split up 16 ways based on some weighted population factors. The 63 million does not include any additional COVID funding that we've received over the last couple of years. That's just sort of their normal, regular allocations. So the AAAs provide some services directly, care management, information and assistance, but both the federal and state statute dictates that the AAAs are not to provide the services directly, except there are some exceptions based on local need. So the majority of the funding by far is distributed to local service providers. On the next slide, I just wanted to provide a little bit of context, which here in the room, we can't see this at all. So for what the number of individuals served and the services that are provided with those funds. And we don't have the end of federal fiscal year 22 report yet because we're still in federal 22, but last year, the AAAs served over 240,000 older adults through choice, just for 60 plus, social services block grant funding, 60 plus, and Title III. They were contacted over 630,000 times for information and assistance. They funded nearly 400,000 hours of personal care services, which was primarily attendant care. And they supported the provision of over 2 million meals last year. On the next slide is some data related to caregivers. And just to highlight a couple of key points, the AAA supported over 34,000 hours of respite care to support caregivers and help ease any caregiver burden, and through caregiver targeted information and assistance. So outside the 630,000 other calls, they reached an additional nearly 38,000 individuals. Next slide. So I really wanted to spend some time just reviewing the statutes related to the AAAs, both on the federal level and choice, with so much focus on MLTSS and so much going on, as Leslie just talked about. This critical role that the AAAs fill at times seems like it might be overlooked. And the Division of Aging has the responsibility to continue to maintain valuable, local, accessible support fulfilled by the AAAs today. And as new and different players possibly enter the current system of long-term services and supports, we really want to make sure that we work to ensure that there are seamless transitions and warm handoffs between various programs and providers. And we really have a great opportunity to work on this right now, which I'm super excited to share. The Division of Aging recently was awarded a grant from the Administration for Community Living related to improving access to long-term services and supports for individuals and caregivers. The announcements just came out on Friday. Through this grant, we will work to establish a governance structure to develop and support a high-performing system of access to services for long-term services and supports regardless of payer source. And really this is fundamentally what is meant by the term no wrong door system. So we will have the opportunity to assess and analyze how individuals are accessing services, specifically long-term services and supports, and look for gaps, which is so incredibly important right now for the state to understand this as we're going through this transition. We want to ensure that there aren't any gaps or that we're not setting up processes where people will likely to fall through the cracks. So I'm envisioning a lot of flow charts and process maps, and once
sounds so exciting.
I really am. So then we'll develop a plan, like, okay, what are we going to do with all of this information? So I think this opportunity really came at a perfect time as we're going through this transition, and I know that you'll be hearing more about it over the coming months. I will pass it back to Leslie to, yes.
So those are some pretty impressive numbers as far as the number of people that you've served and the different categories and sections that you serve. So based on the goal of 75% moving to more of what the AAAs provide, and then also given the number, just the sheer volume of people that are going to be hitting that age range that'll qualify for services, what are your projections then for the numbers that you're going to serve in the real near future?
So I don't have that data with me, and those numbers were completely outside of any of the Medicaid funded home and community-based services. These are just our grant funds that we receive. There are wait lists in some areas to access these funds. It really varies. There are some AAAs that, or some service areas where there are no wait lists. Some have a couple hundred waiting. And probably Kristen may be able to speak to this a little more, but there has been kind of ongoing advocacy to try to increase the allocations for these grant funds at the federal level. And I know every year there's always a push to increase the choice allocation as well.
Would it be a hard ask to, like, maybe for the next meeting, try to get some of those I'm just trying to figure out.
I can work on putting something together and pulling something.
I'm just curious as to what, because then you'll be able to know kind of what the workforce needs that you're looking at and all of that.
Because all of the workforce conversation impacts these programs as well.
Right. And I presume that the AAAs aren't looking to be like the sole provider of all these things, right? They're probably looking for private entities to come in and help fill the gaps on some of that, or no?
I mean, this funding is going to funnel through the AAAs because federal and state statute says it has to, but they do, have to work with local provider.
Okay. Yeah, I would just be curious as to what the numbers that we might be looking at, and
yeah, I have some population growth number.
Yeah, again, I'm a wall. So.
Okay. Right. Thanks.
Thank you so much, Erin. That's really helpful. And sometimes people don't realize the Division of Aging is the state unit on aging, part of the Aging Services Network, connecting the federal to the regional area agencies on aging. And that's why the Commission on Aging, we're very connected with what's happening here and learn a lot. We also review the state plan and in an advisory role.
I do have one last slide here. So again, just wanted to highlight a couple of things that the Division of Aging is working on outside of the LTSS project. So the dementia strategic plan we all heard about from Dawn Butler at the last meeting. So that work is ongoing and continues. I know she's started to ramp up some of the stakeholder engagement for finalizing a strategic plan and really coming up with ways that we can start implementing some of the things in the plan. So some really exciting things coming up for that here in the coming weeks and months. Another thing I wanted to highlight is the master plan on aging. So we have started to kick off a process for our master plan on aging. What that is a cross-sector state-led strategic planning resource that can help states transform their infrastructure and coordination of services for our aging population. So we in Indiana, we're working with the Center for Healthcare Strategies for technical assistance for developing our master plan on aging. It will be a 10-year plan for a healthy and equitable aging in Indiana. So we are just now kicking this off. So you guys will hear a lot more soon on this, and we will start reaching out to stakeholders and hoping to get lots of engagement across all different sectors, because aging is a lot more than just the work that we do in the Division of Aging, certainly. So we want to make sure that we really take a big picture look with this and really hit it out of the park. The dual eligible work, again, it's just a lot of coordination work that we're doing, and Dr. Council, our chief medical officer, is heavily involved in that work and really spearheading a lot of that and doing a lot of really impressive things with that. So hopefully we'll have an update from him in the next couple of meetings too, just to provide some more information there. I did want to give kudos to Erin for the No Wrong Door grant that we received. She really spearheaded that for Indiana, and we're all just really excited about it. So I think we're going to have a lot of good opportunities to explore with that. And then part of this too is an internal assessment for the Division of Aging. We are also in a time of change, so we are doing some work over the coming weeks and months to think about what we need to look like as a robust state unit on aging and what our priorities need to be. So we'll be doing a lot of that work internally just to make sure we are doing everything that we can be doing and should be doing to support aging Hoosiers in Indiana.
Sound like you're a little busy.
A little bit, you know, it's all good, right?
Wow.
Fun challenges, so.
Well, thank you very much. Thank you for all you're doing as we move into some rather major changes here in Indiana with deinstitutionalizing care of older adults, although we still need institutional care. Safe care.
Yep.
In whatever setting it might be.
There you go.
Thank you.
Thank you so much. Okay, I will give an update on the Living Longer, Living Better committee. Right now, I'm continuing to work with the Indiana Library idea for the Indiana public libraries across the state of Indiana, the public libraries across the state of Indiana, to have a as part of their website, to have a page that will have links to that will explain public funding for older adult services. So I have looked at the Division of Aging, and I certainly hope that as NLTSS rolls out, it gets really clear how that works. We want to be sure the area agencies on aging are clearly on that so people understand that. Medicare, Medicaid, Social Security, etc. Because what we're seeing is people go on Facebook and ask other people in communities about some of this, and the responses are real interesting. Let's put it that way. Misinformation everywhere. So can't we make this clear to the public, transparent and clear, with reliable information? And that's why we're looking at libraries to do that and to read. This is not for marketing, it's for education, make it clear. So that's what we're working at. I'm starting with one library, and we get a template. They're going to take it to the Indiana libraries. Roll out just so people are going to get that to a place where they have reliable. If anybody has any comments, I'll convene that group that I worked with to develop the guide, so I get input from them as to who's on it and how we do that. But not to market, but to get clear information. So that's ongoing. Judith, do you have a report from shared decision making?
We've not done anything lately. After my accident, I really have not been up and going, as you can tell. So we're going to try and get moving a little bit more and trying to get a little bit more done now that I'm at least walking.
Okay, thank you, Judith. We are going to get everything covered, including Dan and Kristen here. So Dan, update from the Senior Center Coalition.
Yeah, the goal of the coalition is really to improve senior center services in Indiana. And so along that, we are having a brown bag session. And if you know senior centers in your area, please direct them to our website. It'll have schedules and some of the details for folks to be able to get connected with us. The brown bag session next Friday at noon is going to, the topic is called Quiet Quitting. I'm dealing with burnout, stress, overwork, and the effects on productivity. And I think all of us know, coming through COVID, we're pretending that everything is fine, but the reality is our staff are really beat up. There was just a lot on, especially folks who are working with older adults. And so we're trying to figure out ways to take care of our staff a little bit better through that. We also will be having some regional meetings next week, the North region, Central, and South. One of the things that we'll be sharing at those meetings is a video that we recorded a conversation with Dr. Christina Box, who's the State Health Commissioner, and Leslie Huckleberry, talking about, as we move into the fall, what to expect with flu season, with COVID still hanging on, and then also mental health concerns and ways that we can address those with some of the folks that we serve. At the same time, I would also say that when we're talking about community care coalitions, one of the things that we have talked about was the value of also piggybacking on existing coalitions. And an example is in Bartholomew County, we have what we call the Healthy Communities Council. And one of their objectives coming into the new year, one of the things that they wanted to look at was suicide prevention. And as is often the case, we focus on teen suicide, when in fact teen suicide is one of the smallest demographics when we're looking at that issue. Seniors by far make up the biggest group of folks who commit suicide. 85 and up is the largest single demographic by percentage. Men 65 and up is really the largest group. And one of the issues that we face is that those numbers are probably even underreported. And one of the staggering stats is that when young people attempt suicide, 1 in 200 is successful. That number is 1 in 4 for older adults. So it really is a big issue, and it's something that we were able to advocate, because when they, at the Healthy Communities Council, when they mentioned they were going to focus on teen suicide, I was able to advocate for the fact that we really also need to look at suicide as an issue among older adults. And so that has been amended, and now that will be part of their movement going forward. And so by being able to kind of partner with an existing coalition, we were able to move senior issues further toward the front and get those on the docket. So we also have a Facebook page, so if people would like more information, they can find that at our website and also on our Facebook page.
Okay, thank you so much. Dan, comments, questions? Okay.
Dan, what website are we looking at? What's the address?
The millricecenter.org is the actual address. We host the Senior Center Coalition website there. We will have our own website starting in next year, but right now it's hosted by Millrace Center.
Thank you.
Thank you. Kristen?
Hi, everybody. It's good to see a lot more people in person. Yay. So I want to focus on some federal updates, some state updates. There's a big portion in your education packet, which I sent to Willie last night for distribution, that focuses on housing. So there was a big discussion on emergency housing. Quite honestly, housing is a crisis for everybody, but particularly so for older adults because the additional support needs. And so I've kind of included in the packet just some different perspectives on housing needs for various ranges, not just the very low income or the low income or people who are SNF eligible, but even people in the middle income market. People older than 50 are the fastest growing portion of the population who are becoming homeless because of the way our housing markets have gone crazy. This might be their first experience with homelessness. So we're kind of used to working on these issues from that basis of the very low and low income. But we really also need to be thinking about quite honestly, people just like us who may be renting rather than owning their own home, who are getting their rents jacked sky high and losing housing because of that. Just kind of some context. It's going to need to be an ongoing discussion, and I'll talk about that a little bit more in our state update. So one of the interesting things that's happening this month on September 28th is the White House Conference on Hunger, Nutrition, and Health. So they are trying to kick off a national focus on hunger, nutrition, and health, and there have been advocates of all stripes as well as consumers and providers, et cetera, contributing to these calls the White House team has been having nationally. All kinds of people are hungry. And so this is a focus not only on older adults, but children and college students and families, et cetera. There are opportunities to host satellite events, and if people are hosting satellite events that are open to the public for more than 25 people, they will be posted on the website. So I would encourage you to look into, looking at the website, for which you can find from your packet, to see, number one, you can host a listening session. You can host a virtual session along with the White House conference. There's a toolkit on how to do that. The second thing is just participate. Even if you don't have the capacity to host a session yourself, you as an individual can take part in the live stream. So the White House is trying to make a bunch of big announcements about various commitments that have been generated as the result of this conference. And so it'll be interesting to see what kind of commitments and new strategies they're going to come forward with. It's designed around 5 broad pillars. So it's not necessarily population based, like this is what we think about senior housing, and this is what we think about housing, hunger and family hunger and child hunger, et cetera. It's a little more broader than that, but you'll find a lot of tie-ins with the work that you do. So kind of our connection with the AAAs is obviously the meal programs, as well as the evidence-based healthy aging programs. So we've certainly been paying attention to that as that's been coming along. So in alignment with that, AARP in March came out with a fact sheet on older adult food insecurity. There's some articles in here just about how inflation is affecting older adults overall, including food prices, et cetera. Another thing happening nationally, or not happening as the case may be, is the federal budget. Because of the elections, there's not going to be a federal budget passed before the end of the fiscal year, which is September 30th. And so the thought is they will try to pass a continuing resolution to keep the government up and running and through December. And that's disappointing news for us because there was such a small increase in Older Americans Act funding last year. We were really hoping to be able to move forward a bigger increase this year, but in a continuing resolution, it stays at the same funding level as the previous year. So we really want to try to move people off that continuing resolution, but that's kind of the main federal focus now for federal advocacy. The other big thing that happened federally was the Inflation Reduction Act, and it affects the people we serve primarily through the changes to Medicare and Medicare drug pricing. So there are information sheets in your packet about the various kinds of things happening to Medicare that will save consumers money. And there is actually an estimate of how many consumers in Indiana will be affected or helped via those Medicare provisions. The other big thing in that package that affects what we do is the extension of the Affordable Care Act subsidies to make marketplace plans affordable for individuals. So if any of your consumers are in marketplace plans, they'll have continuing subsidies for a while at least. Okay, so that's kind of what's happening at the federal level. Any questions on that? The state level, the interim committees, which normally start up in August, have been slow to get going, primarily because of the special session that took place, as well as the fact that everybody's campaigning right now, even at the state level. So we aren't as far along with the interim study committees as we normally are. in general. I think I shared this with you a couple meetings ago, but I've included the study committee topics that we're going to be following, which include housing task force, as well as some things in the public health committee related to insurance, as well as kind of the ongoing discussion around THC, medical marijuana, that kind of thing. We've never taken a position on that, but because we know, especially veterans may use medical marijuana or marijuana for medical situations, we kind of try to keep up to speed with what's happening there. So I'll keep you posted as that moves forward. The Housing Task Force is ostensibly focused on workforce housing. And part of our job is going to be to say, remember, older adults are still in the workforce, or they were workers, and we still need to make housing available to them. But also bringing forth data about kind of the overall housing needs in general so that our populations don't get lost in that conversation. So those meetings have not started yet, but we'll keep you updated as those move forward. The other big thing that's happening at the state level right now that is of interest to us, in addition to the great news about the ACL grant on No Wrong Door, as well as the movement forward on the Master Plan on Aging, is the report that the Governor's Commission on Public Health put forward, calling for a $250 million investment in Indiana public health, including funding for local level public health. And it's our hope that with the new focus on the Master Plan on Aging, cross-sector, public health has a big, important role to play in healthy aging. And so we're going to be continue to look for opportunities on how we can influence how that moves forward, advocate for it in the General Assembly, but also kind of administratively, or if necessary, legislatively, make sure that issues affecting aging are covered in that public health planning and investment. And so I keep saying the governor needs to have next level aging, right? Next level everything with our governor, next level aging. And so between that public health plan and the Master Plan on Aging, I'm hoping that can come together to be that next level aging initiative. Everything else in here, there's a big focus on housing. There's a big focus on just expense. People are being priced out of living is the concern, between not having money for housing, not having money for healthcare, not having money for food, et cetera, with everything kind of skyrocketing. So there's data in there, various reports to provide some perspective on that. Interestingly, there's also a few articles came up about cognitive rehab for long-term COVID, how we can protect our cognitive health, et cetera. So I just thought that was an interesting set of issues coming up about the same time. And finally, your last page, which I just had to include, is the workforce of toddlers that apparently exist in some Japanese nursing homes. And so community members are invited to bring in their toddlers for engagement with the older adults. It's a win-win because the toddlers get to engage with people outside of their family. They may get diapers, they maybe get food vouchers, et cetera. And of course, the older adults love interacting. So I'm putting you all on notice that if I need to go to nursing facilities, stick me in Japan where you can have toddlers coming in. But I just thought that was the cutest thing. So a lot of depressing news and a little bit of sunshine in your pocket.
You can find toddlers in Indiana and nursing homes.
Yeah, yeah. In your spot? Good.
Dogs, toddlers. Yeah, it's normal.
But are the toddlers part of the workforce? That's the thing. They're officially workforce. So,
Well, yes, they do some activities for our folks.
okay,
So,
okay,
yeah,
all right.
yeah.
Kristen, with the housing issue and homelessness increasing, is there a correlation with substance use disorders among older adults as being maybe one of the root causes of that? Is that something that people are looking at right now?
You know, I'm not seeing that. I don't know the answer to that. It's not something I see in the media. You know, when I bring these things in, it's kind of like, oh, I'm seeing like a bunch of articles on this in the media at this time. I'm not seeing a lot of that discussion, but I appreciate what you're saying about suicidality in older adults, and you know, all that stuff kind of feeds in, right? Dual diagnosis, et cetera. So a lot of what I'm seeing right now is just really that kind of inflation focused discussion. You know, housing for the last couple of years because of the housing markets, and now we're seeing the food inflation, transportation inflation, et cetera.
Yeah. And our local task force for substance use is noticing increasing numbers of older adults who are dealing with substance use disorder. And part of it is because boomers were, you know, the sex,
Right.
drugs, and rock and roll generation, and they're still trying to party like it's 1969 with 70-year-old livers, and that's, you know, that's really an issue. And we're seeing more impact now among older adults that wasn't there before.
When the Mental Health on Aging Coalition was active in our state several years ago, that was one of the things we talked about. We're going to have all these boomers that were more likely to be involved in substance use and abuse, aging into the system that we work with. I did talk with somebody at the Department of Mental Health at the HCBS conference in DC, and she mentioned they are in the process of bringing on somebody that will have an older adult focus. I think that was kind of like, you know, it's in the plans at that point. It's not a done, at that point, it wasn't a done deal, or, you know, but I'm hoping that we can engender that kind of specific population focus again with the Division of Mental Health. Okay, thank you.
Thank you so much, Kristen. Well, another rather dynamic and exciting session here today with lots of discussion. As our older population in Indiana continues to grow, and we know it will for a while, we certainly have a lot of work to do, but it seems to me like we're making some progress, and we need to celebrate that along the way too. But let's continue to work together to see how we can improve the quality of life for our older Hoosiers. And we hope to see more of you here in November. And thank you very much for your time today. If there's no other business to be brought before the commission today, the meeting is closed. Thank you so much.